know me, I'm Matt. I'm an R1. And as Dr. Freed mentioned, I will be discussing whether or not patients who are tube fed should be NPO after midnight. So just to start by defining a few terms, NPO stands for nil per os, and it refers to a period of time before a procedure takes place when a patient is not allowed to take in liquids or solids. And the great fear of patients taking in liquid or solid after midnight prior to a surgical procedure historically has been pulmonary aspiration, which is aspiration of gastric contents, which can lead to things like hypoxia, pneumonia, prolonged mechanical ventilation, and fatality in certain patients. And then to define what a feeding tube is, I'm sure we're all familiar, but most commonly it's an 8 to 12 French flexible tube inserted orally to the antrum of the stomach or possibly post-pyloric to the duodenum jejunum. It's used for enteral nutrition, but also can be used for decompression. Why this topic matters. Surgery is a known stressor to the body, and it mobilizes a metabolic response. It's been shown over and over again that malnourished surgical patients experience higher postoperative mortality rates, morbidity, length of stay, readmission rates, and hospital costs. And therefore, preoperative fasting should be minimized and limited as part of an effort to limit these complications and improve post-op outcomes. The American Society of Parenteral and Enteral Nutrition and Critical Care Medicine recommend minimizing fasting times prior to surgery. In fact, it looks like they felt so strongly about it, they mentioned it twice. Little typo. Origins of NPO, it's extremely relevant to mention where this came from because there's actually not a whole lot of data, or initially there wasn't a whole lot of data to support the recommendations. It was initially recommended to minimize the unpleasantness of vomiting rather than the danger of aspiration per Dr. Snow in the 1800s. The first anesthesia book in the mid-1800s didn't even mention fasting. By the time the reason why it caught on was because there were a number of studies, some done on peripartum patients that had aspirated intraoperatively, some done on emergency surgeries that were done in patients with full stomachs that had showed higher rates of aspiration. And these were then extrapolated to just healthy patients undergoing elective procedures that having any sort of food in the stomach would lead to higher rates of aspiration. But the first randomized control trials weren't performed until the 1980s. A couple that I listed here, I'll just talk about one of them that's up here. It showed that there were 3 different groups. One had consumed 150 mils of coffee, 1 orange juice, and 1 fasting 2 to 3 hours pre-op. And there was no statistical difference in gastric residual volume or pH once the contents had been suctioned and compared between the 3 groups following induction of anesthesia. And we'll talk about why gastric residual volume and pH are used for determining risk of pulmonary aspiration in a bit. In 1999, the first guidelines from the ASA were published to allow clear liquids until 2 hours pre-op, given the studies in the 1980s. And then this last study is just to illustrate that we're still continuing to look into how long different liquids hang around in the digestive tract. This study showed that it was actually further differentiating between orange juice with pulp and orange juice without pulp, showing that within 3 hours, both orange juice with pulp and without pulp had returned, the gastric residuals had returned to baseline, which was defined in this study as 1.5 mils per kg, which sort of came about arbitrarily as well. So these are the current recommendations by the ASA, the American Society of Anesthesiologists. This was based on a 2017 task force and meta-analysis that had compared preoperative gastric volume and pH in patients who had consumed various different liquids. So you can see that clear liquids are supposed to be held 2 hours pre-op, breast milk 4 hours, infant formula, non-human milk, and light meals 6 hours. And then fried foods, fatty foods, or meat can be 8 hours or more, depending on the situation. Unfortunately, these times, patients end up fasting for a lot longer than these times, just because if we're unsure when a procedure is going to happen, usually on the medicine service, we only know that a procedure is going to happen the next morning. We're not told exactly when. So if you were to be told that a procedure could happen anytime between 6 a.m. and noon, you're going to hold them at midnight just in preparation for that procedure. So there's a lot of nutritional deficits that can take place when you put someone who's critically ill, for example, somebody who's being tube fed, on a fast of that duration. So what about tube feeds in critically ill patients? So the ASA recommendations that we just talked about, those are for bolus meals in relatively healthy patients undergoing elective procedures, rather than critically ill patients who are receiving tube feeds continuously. It doesn't really compare. Just based on the content of the formula of tube feeds, it would fit into the light meal category of the 6 hour fast. However, it hasn't. Further studies obviously need to be done to look at how a bolus meal compares to continuous feeds. So we'll continue to talk about that. Research suggests that when somebody is mechanically ventilated, the airway is protected by the inflation of the endotracheal tube cuff, and therefore the risks of aspiration are minimized. So this is a study that was done in 2014. I thought this graph was nice. It illustrates how gastric emptying occurs in healthy volunteers who ingested 240 mils of clear liquids, and it shows that a mean half emptying time was 13 minutes and return to baseline was 45 minutes. So within an hour, clear liquids are out of the body. This is another study that compared different liquids, so comparing clear liquids, comparing, 2% milk, Ensure Clear, and apple juice, and it showed by 3 to 3.5 hours, all three of these drinks were cleared from the stomach. And I think this is important because this 2% milk is in the same category. If we look, it's a 6 hour fasting category as a light meal, and light meal is what tube feeds are considered. So by under 4 hours, tube feeds, if they were served in a bolus format like this study showed, should be cleared from the body. So why do we use gastric residual volume as a predictor for aspiration and aspiration risk? So this study actually set out to try to determine whether there's a certain cutoff we could use to determine whether or not patients are at higher risk of aspirating. And so patients were separated into 3 different groups. Those with gastric volumes less than 150 mils, less than 200 mils, and less than 250 mils, and then separated into either frequent aspirators or infrequent aspirators based on the amount of pepsin within their tracheal aspirates. 89 patients were listed as frequent aspirators. Volumes less than 150 mils were common in both aspiration groups. So aspiration did occur in patients with less than 150 mils of gastric content. The conclusion is that there's no consistent relationship between aspiration and gastric residual volumes. However, aspiration did occur significantly more often when volumes were high, as you can see with a p-value of 0.008 in patients with 2 or more instances of having 250 mils of gastric content. There was a significantly more amount of high aspirators. I thought that this study was really helpful. So this study actually set out to determine whether or not a high or a P4 formula would be preferred in critically ill patients compared to a casein dominant formula, just based on the belief that there may be some coagulating factors within this casein dominant formula that prevents it from emptying from the stomach as quickly as this other formula. So the conclusion from this study was that faster gastric emptying with the P4 occurred with P4 compared to the casein dominant formula. Why I thought that this study was helpful was because it showed mean gastric content at different hours throughout the study, and so patients were fed enterally continuously at 100 mils an hour for 4 hours, and then their gastric content was measured. And as we could see, at 3 hours they seemed to peak, and at 4 hours they probably had reached a steady state, I'm assuming, because their gastric content had actually started to reduce. And then at 5 hours, 1 hour after tube feeds were stopped, their gastric volumes reduced to 81 mils and 116 mils respectively. And I think it's less important for our purposes here to compare the differences and rather just to look at both of these different formulas, one that is known to empty slowly. Both of them within an hour are well below the 250 mils that was shown to cause to cause you to be at risk of being labeled as a more frequent aspirator. This is a study that looked at basically took a look at how the nation handles enteral nutrition and tube feeds in critically ill adults perioperatively. And it was a meta-analysis, it reviewed 14 different studies. Fasting practices, safety concerns, and clinical outcomes were all looked at. I was surprised to find that there was huge variety in fasting reasons and safety concerns among institutions. So I was under the impression that most people understood that the main risk is aspiration. That's why you hold feeds prior to an operation. However, there were a number of different reasons listed as the primary reason. Some institutions listed ARDS, which can be a result of that aspiration. Many commented on aspiration pneumonia. Failed extubation was also commented on. So it seems that there is some varied understanding in why patients are actually held, why feeds are actually held. There was only one randomized control trial that was identified. So in this study, confounding and bias may be present. This is a randomized control trial. I believe this is actually the one that was mentioned in this review. It was a single center parallel group RCT. It included trauma patients greater than 18 years old requiring mechanical ventilation for greater than 7 days receiving enteral nutrition. The control group received a 6-hour fast, which is the standard of care at this institution. And the intervention group received a shortened fast of 45 minutes, as well as early initiation of enteral nutrition. And the results showed that the intervention group received significantly more calories, not surprisingly, and protein than the baseline group. The percent of patients receiving enteral nutrition within 24 hours of ICU admission also increased, so there was another variable at play here. The intervention group had more ventilator days than the baseline group, but also a significant sex and injury adjusted reduction in pneumonia, which I thought was surprising. So conclusion, implementation of multi-targeted feeding strategies resulted in a significant increase in nutrition adequacy and reduction in pneumonia. This is another review of kind of similar to the one mentioned 2 slides ago. It included 3 studies, 128 participants in 8 different fasting protocols. And the clinical outcomes showed that there was no aspiration events witnessed during any operative procedure where reduced fast was used. So also supporting this idea that a reduced fast, and here it doesn't actually. There were 8 different fasting protocols, so the trend was that with shorter fasting, there weren't any aspiration events identified, and so suggesting that, this is something that is reasonable given possibly just how infrequently it occurs. This study actually isn't entirely relevant, so I'm just going to briefly touch on it. It showed that this is talking about extubation, continued enteral nutrition, teleextubation compared with fasting before extubation in the intensive care unit. The conclusion was that enteral nutrition, teleextubation was non-inferior to a 6-hour fast strategy. And this was being compared, 6-hour fast strategy with gastric tube suctioning prior to extubation. So represents a possible alternative strategy. So should tube feeds be held preoperatively? I think that based on the data that I reviewed, it's sort of a case-by-case situation where you have to weigh the malnutrition risk and the consequences of malnutrition, as well as the aspiration risk and the aspiration consequences. There are a few different ways that you can stratify patients' malnutrition risk. Recently, Duke published this PONS score where you take a look at BMI as well as albumin and vitamin D. As well as other things such as weight loss, and if you've been eating your normal diet in a week prior to surgery. And then there's also other strategies like using muscle-specific ultrasound to identify lean body mass. I thought that this was really interesting. So these tools can be used to stratify patients based on that. I think more importantly, it's important to understand that there are certain patients that are going to have a lot higher metabolic requirement, including burn patients. Burn injury may increase metabolic requirements up to 200% of normal and make it challenging to meet protein calorie demands when feeds are withheld. And then you can separately stratify based on aspiration risk. So although pulmonary aspiration is a serious complication of anesthesia and can even result in death in certain groups, it's relatively uncommon and occurs in about 2,000 to 3,000 operations, with almost half resulting in lung injury or pneumonitis or aspiration pneumonia. So even when it does occur, only about half the time is it causing any downstream consequences. However, important to recognize though that patients who are receiving tube feeds are going to be more likely to experience these complications. Conditions that affect gastric emptying or fluid volume, like pregnancy, obesity, diabetes, any hiatal hernias, GERD, ileus, bowel obstruction, tube feeds, these should all be considered when assessing aspiration risk. Oral pharyngeal dysphagia, suppression of airway reflexes, known difficult airway, critically ill patients. Something that's being used that has been validated in a study that I'll talk about in a moment is antral cross-surface area via ultrasound. So taking an ultrasound to the stomach and measuring in right lateral decubitus the cross-section to assess how much residual feed is within the stomach. And the study shows that a cross-sectional area of about 7.5 centimeters is equivalent to gastric volume greater than 100 or 1.5 cc's per kg. So that can be helpful. I mean, I know that we just established recently that we're only really worried about more frequently aspirating in patients with gastric volumes above 200 or 250. And so you would be safe at 7.5 centimeters of a gastric or antral cross section. This is the study that was just mentioned. This is an image showing the gastric antrum would look like in cross section in right lateral decubitus. So I think the best way to handle this is try to optimize a patient before the procedure happens. You can control their GERD with a PPI, you can, or famotidine, you can give them a GI stimulant like metoclopramide if they have any ileus or if they have diabetes. You can give them an antacid, you can give them an antiemetic. You can preoperatively, you can suction their stomach with a wide bore tube. You can, if you do decide to discontinue feeds, you can optimize their nutrition by giving dextrose. You can limit preoperative masking and keep the you can keep the inspiratory pressure below 20, just because that's been shown to be the level of pressure required to open the lower esophageal sphincter. You can intubate in Fowler's position, which is when they're I think you can communicate with the anesthesia team that you have continued feeds so that they can intubate in Fowler's position in the operating room to prevent risk of aspiration. And then you can begin postoperative feeds immediately after the operation. So there's a number of ways that you can optimize a patient, and I think based on these different ways to risk stratify based on their aspiration risk and their malnutrition risk, I think you would be able to decide at that point whether or not tube feeds should be held. I think that they don't need to be held after midnight and can be continued up until the operation in somebody who has a cuffed endotracheal tube in and the cuff is inflated and it's proved that there's no leak. I think that you can still optimize these patients using some of the ideas in this slide to prevent any risk of aspiration, even though they theoretically are protected by that cuffed endotracheal tube. So what is Cottage's policy on the matter? Cottage's policy, updated in this past September, is that patients who are not intubated with tube feeds will have tube feeds stopped 6 hours prior to intervention. In my opinion, based on the studies that I looked at, this is pretty conservative. I think that primarily the study that had showed that within 1 hour or within 4 hours of receiving tube feeds at 100 mils per hour, the gastric content was around 100 to 115, from what I recall, and comparing that to the study that had showed that a gastric content of 200 to 250 is when you'll actually start to see aspiration more frequently. Holding tube feeds for 6 hours seems conservative to me at this point. Patients who are intubated or have a trach in place with tube feeds will have tube feeds stopped immediately prior to transfer to the OR, and before leaving the ICU, suction will be applied to clear the stomach of any residual volume, which I feel is appropriate. There are exceptions based on the surgery, and then if tube feeds are held, there are instructions on how to try to mitigate any poor outcomes that might occur because of the nutritional deficits in that time period. For example, starting D10 half normal saline, continuing scheduled insulin, obviously in those cases, checking blood glucose frequently, and resuming tube feeds immediately upon completion of the procedure. And here are my references. Right on.
Good. Thank you.
Yeah, thank you.
All right. Any comments, questions, Dr. Ashamala?
Did the studies that you look at comment on full feeds versus trophic feeds?
None of the studies I found commented on the difference.
And then it seems like our policy doesn't cover the difference. Thank you for including that. The reason I ask is the volume of trophic feeds, or just like maintenance feeds, is so much smaller. And in critically ill patients, many of them are not on full feeds regardless. So would be interesting to see in the future how that might affect our policy.
Yeah, one sec. I agree. I think, trophic feeds usually like 20 to 30 cc's an hour. Clearly, the stomach itself makes 50 cc's of gastric fluid an hour. So it's like, and it's cleared. And, I think it probably doesn't need to be held for more than an hour or something before the surgery. But I don't know, we have a dietitian in the back. I don't know what she thinks. I know she was probably part of this recent policy.
Yes. Also helped me out with my presentation. Thank you.
You have any comments before I go to Dr. Seuss? No? Okay. Dr. Seuss?
I was just reminding people that we do not need to remember that entire policy or look it up anywhere. You simply type in EPIC, perioperative gastric feeding, in all ICU patients, and this will be taken care of by nursing and anesthesia, and everyone already uses that. So you don't even need to worry about one more.
All right, well, I guess it's time to vote. I think that, there really hasn't been, as far as I know, a randomized controlled trial looking at this. And I think we're the original recommendations for NPO after midnight came like 100 years ago, based on really somebody's opinion, which is where a lot of these myths come from. So we don't really know. There really wasn't a basis for it in the beginning. There's been some studies done since then. I'm not aware of any studies. Really, none of the studies that you presented looked specifically at tube feeding, gastric residual volumes. There are studies about that, but most of them use gastric aspiration, which has been shown to not correlate with the actual gastric residual volume. So that's why we don't check residuals anymore. But I think that a lot of the studies looking at aspects of this, such as, giving people a certain volume of fluid and seeing how long it takes to clear, I think clearly it takes less than 6 hours for something like tube feedings to clear from the stomach. Probably 2, 3, 4 hours. That's my opinion. But let's see what everybody else's opinion. So how many feel that this is a true statement that we should you have to hold tube feeds after midnight, NPO after midnight for pretty much any surgical procedure in tube-fed patients? Nobody. How many feel it's possible? There's one. And how many feel this is busted, that it's not? Okay. All right, well. All right, we're busted. Before you all leave, I want you again to wish you all a happy holiday season, one filled with joy, peace, and hopefully an absence of disinformation, conspiracy theories, and myths. So have a happy New Year. See you next year.